welcome to Cure Talks at Penn. I'm Priya Menon, and today we are discussing a new study testing the effectiveness of a male contraceptive gel as a possible new method for male family planning being conducted at the University of Pennsylvania. We have with us the principal investigator of the study, Dr. Barnhart, and director of operations, Elizabeth Steider. Joining us as part of the advocates panel is Dr. Logan Nickels, Director, Male Contraceptive Initiative, and author and fertility coach, Kristen Darcy. Everybody, thank you very much for being here. I'm going to start by asking Dr. Barnhart to talk a little bit on what the study is about, touching upon some of the primary objectives that we are looking at in the study.
Sure. We're really excited about this study because it really is kind of groundbreaking. We've been studying here at the University of Pennsylvania methods of family planning for a long time, and we're happy to say we've worked with some companies bringing them to market and new ideas as well. But this one is exciting because we're studying not only methods that'll help women, but actually help men as well. So what we're really studying is hopefully the first commercially available male contraceptive. And that male contraceptive is in the form of a gel, which contains two hormones, one called testosterone and one called testosterone, which will allow a lowering of the sperm count, therefore allowing a couple to enjoy contraception. This is what's called a phase 2B study, meaning it's both a combination of proving that this works well and as we intend and safely, but also in a large number of women and couples, I should say, that it actually does provide safe contraception. So I'm happy to talk about that study. I'm very excited about it. I think it really can have great impact.
Dr. Barnhart, as you know, this is really truly exciting when I read about the study, and definitely would open up more options for couples. And I think you just did mention that it's a combination gel. Can you delve a little bit deeper into the mechanism of action of this gel, and what are some of the side effects, if any, that we are looking at?
Sure. So let me start by really high level. In women, contraception has been a little bit easier because we can separate, for example, ovulation or the egg itself from all the other characteristics a woman has. So we can actually stop the egg from ovulating without affecting any of her other hormones or side effects. In men, it's been a little bit harder because the testosterone that a man makes gives the man his characteristics as well as drives sperm count. So what we're using two drugs to take care of that. In other words, we're using one drug called testosterone, which is the progesterone, which works on the body's pituitary gland to say, stop making testosterone or stop driving the testis to make sperm. And we know that if left alone, would lower a man's sperm count, but also lower his testosterone and therefore have side effects of low testosterone. So the second drug that's a combination of this is to give back some testosterone such that we are at the same time giving him, maintaining the man's symptoms, side effects, profiles, everything about him that makes a man, while lowering the sperm count. So it's a combination of both the progesterone to lower the sperm count and then giving back some testosterone to allow him to have the normal symptoms and the normal life that he should enjoy.
And what are some of the eligibility criteria that we are looking at?
Yeah, so so basically this is looking for healthy couples. Anyone is potentially eligible as long as they're within a certain age. I believe it's 18 to 50. But generally we're starting with the idea of healthy couples that could get pregnant on their own, that want contraception. People need to be in the study for almost up to 2 years, but at least a year where we're testing to see whether it works as the contraception. So one of the main criteria is couples obviously don't want to have children in those 2 years. So really it starts with a pool of healthy couples desiring pregnancy, but not yet. And then we start excluding people mostly for safety reasons. We don't want to enroll men that already have some side effects that might be exacerbated by testosterone, like high blood pressure or enlarged prostate or things like that. But again, we're looking for healthy couples, and then we'll go through a series of very specific criteria to make sure that it would not be a good contraceptive option for them for things like blood tests and blood pressure and things like that.
Mm-hmm. You did mention that the couple should not get pregnant during the course of the study. So what happens if a couple does get pregnant?
Well, there's kind of two phases to the study. The actual study is looking to try to get a couple to use this for a year and to see if it works. Like many female birth control studies, we want to study it for a year. How effective is it in a year? But it takes us a couple of months to get the couples ready, and then there's a follow-up period. So they're really in the study for around 2 years or up to 2 years. So in the first part of the study, we don't want the couple to get pregnant, so the woman is using her own kind of birth control, and then we're assessing its efficacy for a year. If a couple, there is a possibility people can get pregnant. In all birth control methods have a failure rate, and we will monitor that and follow that along. But there's no evidence that if they do become pregnant while using this, that there's any harm to the baby or harm to the pregnancy. So like any couple that gets pregnant unexpectedly, we would help them diagnose the pregnancy and make sure the pregnancy is progressing fine, and then the couple can make their own decisions on how to proceed.
Beth, I'm going to pull you in here. So as Dr. Barnhart just mentioned that we're going to be enrolling couples. So what is the consent going to be like? Will the couple have a single consent, or would they need to do this separately?
Yeah, so typically the conversation is done together, but each partner does consent for themselves. So, prior to any research procedures, they would go through a consent document in detail with a member of the research team that would talk about, everything that was planned for the study, visits and procedures, testing, information about risks and benefits, explanations about, how we would keep their information confidential, et cetera. Basically everything that they really should know in order to make this decision. And then they will each sign a consent form specific to their role in study participation because, requirements for each partner are different. And, prior to that, we make sure that they have ample time to review it and discuss it amongst themselves and with others if they wish prior to making that decision.
But can you also talk a little bit about what would be required during the course of the study in terms of clinic visits, how many times visit, taking questionnaires and tests? Could you talk a little bit?
Yeah. So, as Dr. Barnhart had mentioned, there are a few different phases of this study. During the suppression phase in the beginning, initially, there is a screening visit to sort of determine if they're eligible to begin the study. And then, once suppression starts, that lasts up to 4 months. And during that period, the male partner needs to come into the office about every other week. And what we're looking for primarily there is to do semen analyses to see that the male partner's sperm count is lowering, because we need to see that dip down to a low level in order for them to be eligible for the efficacy phase of the study. There's semen analyses and blood work. There are some physical and andrological exams for the males throughout. During this suppression phase, there's not a lot that the female partner needs to do. She'll be keeping a menstrual and coital diary during the course of the study. So that will occur during all phases. And then during the efficacy phase, the male partner will be coming in about once a month. And as Dr. Barnhart mentioned, that's a 12-month period. During that period, the female partner comes in every other month. Both of them are doing blood work during this time. There are some questionnaires at certain points. And then once they've gotten through 12 months of efficacy, they will enter the recovery phase, which is up to 6 months. The male partner will continue to come in about once a month for those same kind of tests. So, opposite of what we were looking at in the beginning, we're looking to see that sperm count go back up to normal. Ideally at the end of the study. And during this period, the female really only comes in once, and then the male has a final visit. So there are many more visits for the male than the female, as you might anticipate with a study of this kind.
Thank you, Beth. Logan, I feel this is a very interesting trial that I'm sure the community at Male Contraceptive Initiative would find intriguing. And I'm sure you have questions for Dr. Barnhart. Please go ahead and ask your questions.
Sure. I think this plays into just what Beth was talking about. Could you talk a little more about the suppression and the recovery phases and what patients might expect in terms of a timeline before efficacy and return to fertility? I think a lot of people are coming to terms with all the talk about vaccines and the time between a treatment and efficacy. And I think for this particular treatment, that'd be pretty interesting for patients to understand what they can expect.
Sure. Again, this is, I don't want to use jargon, but this is not yet a phase 3 trial, meaning, we just want to prove that it works. We're still doing a little bit of fine tuning. So the suppression part of this phase, which takes a few months, is basically to see how quickly the sperm count goes down and how many people it actually goes down to a level we think is going to be contraceptive. Once we've reached that, then we enter the phase where, all right, let's use it as a family planning method for up to a year. If a couple decides they don't want to use it anymore, the year is up, then they stop taking the gel. And we think the sperm count is going to come back up to where it was before, but we want to assess that. That's why there's that recovery period of around 6 months, so we can actually see how quickly does it come back and does it come back to normal. We estimated that will be up to 6 months, but sometimes the sperm count comes back very, very quickly and you don't have to wait 6 months. But we want to make sure we have a long enough period that we see everybody recover. So this is obviously not the way it will be used in real practice. But the idea is that we can very quickly and scientifically understand how it works to suppress the sperm count, how long it maintains that way, and then how quickly people come back to normal levels, because we want this to be safe and reversible. We want this to be an option, not a permanent thing.
So I have a quick follow-up on that then. Should this gel, become approved and be available to the public, would users potentially go to a primary care doctor to get sperm counts? Would that be something they'd be potentially able to do at home? I know there are a lot of products that are making their way to market now to do home fertility checks. Do you think that's a possibility?
Well, it's going to be fun to speculate because we obviously don't know at the moment. But that's why we do a study like this, because we want to be able to inform those kind of questions. If after this study, which is, by the way, done around the world, this has been done in Europe as well as multiple places in the United States. We're really happy to be one of the sites, and we think this is going to be terrific. But the study is going to answer those questions, like how sure are we that the sperm count goes down to 0, or do you need to check a sperm count at home? There are, as you mentioned, there are ways to check it at home. We hope that that's not going to be mandated. And we want this product to be very confident that if you use it for this period of time, your sperm count will be low enough to work as family planning. And then we want to be able to confidently say, and whenever you choose to stop it, your sperm count is going to come back to normal in X period of time. So hopefully those questions will be answered. How it's administered is again, we can talk about that all we want, but it'll depend. There are questionnaires in this trial that ask both the male and the female partner, who would you prefer to prescribe it to you? Do you want it to be your family doctor? Do you want it to be a pharmacist? Do you want it to be your urologist? But that's all just gathering information. We really don't know how this will be rolling out, except that if it is safe and effective, it should be widely available.
Right.
One other question that I had was about the gel itself. Can you talk a little bit more about how men would use that gel, and then maybe what are some of the upsides or downsides of using a gel for delivery instead of a daily pill?
Yeah, sure, happy to. I think the gel is a very clever idea. So the idea is that both of the hormones I mentioned before are mixed in a gel. So you don't have to worry about the dosage. You don't have to worry about, is the concentration right? You don't have to do anything other than take a little canister and push down on it and get a pump of gel onto your hand. Those canisters are made such that they give very close to the same amount of gel and therefore the same amount of drug with each pump. And a man uses 2 pumps, one on the right shoulder, one on the left shoulder. Shoulder, arm area is the idea. And then the hormones are absorbed through the skin, and they absorb relatively slowly. It's not like just one dose of hormones. They absorb as the gel, mildly over the course of the gel for a couple of hours. there are a little bit of limitations that people are going to have to learn how to use. For example, the gentleman shouldn't shower for 4 hours because you don't want to wash the dose away. So, find a time in the day where that's comfortable for you. But generally speaking, it's easier than taking a pill. It's not difficult to apply a gel to yourself. So I think it will be very acceptable.
Awesome. Thank you.
That's great. Well, I have a question. Not a question, but when I was excited to be part of this discussion because of the overall men's health gap. When men come to 18 and opt out of a pediatric care, there's a gap. And when I see my clients, it's because of the crisis in fertility. And what I was excited about hearing from you is what you just said, is that hopefully this will change the perception for men and their healthcare, their overall wellness, that they will have a continuity of care into whatever choice that you out of the study deems appropriate for men to go to urologist or primary care or whatever that continuation, because what I have found, and I don't know what you're finding in your study, is men don't go to the doctors for their annual physicals. They only go if they're bleeding, and one of the other doctors I work with said, or wounded, So I wonder if within this study, is there any questioning about that? Because I feel like that would bring a wealth of information about men's mindset for their medical wellness.
Yeah, I think that's a really, really important point. Again, we're not going to be able to answer all of those questions with the study, but I'll touch on a few. You're right. Once a man stops seeing his pediatrician and stops getting his physicals to play sports in high school or college, they don't come back to a doctor until they have chest pain at 45 or something like that. So, this is an opportunity that a man not only can take responsibility and make good life choices and use contraception, but might have access to a healthcare provider to check their blood pressure once in a while and do a physical exam. So, we might be able to have a well-man a well-man exam like we do have well-women exams now. So that is exciting that we can keep men engaged in the health system for their own benefit. How it's going to be administered and who's going to give it to them are things to be worked out. But if it really is as safe and effective as we think, I don't think there's going to be pediatricians or family practitioners or internists that are going to be afraid to prescribe this. And, that would be a reason for them to see their doctor, get the prescription, and hopefully, live a healthy life.
So I know you touched on this, but for my clients are really in the throes of trying to create a family. And I was wondering, I love your thoughtfulness about the kind of the arc of the bell curve on the other side of the study about how you're tracking to make sure that sperm count does come up. So has there been conversation about if a man is on this for a 2-year period? I know that you'll probably find this out in the study, but, is there going to be a waiting period before they can actively try to have a child after this?
Yeah, as you know, these are questions that we have to give very firm data on to the FDA so we can make recommendations and things like the label for this product and how to use it. But anecdotally, someone that's worked with testosterone replacement or worked with men trying to get pregnant that have used testosterone replacement for a variety of reasons, or even for athletics, we know that the sperm count really does bounce back pretty quickly. But the idea is you don't want to take my word for it. We want to get a number on it. We want to be able to say, it'll come back 90% of the time by X date. There are people, again, anecdotally in this trial who have conceived a pregnancy 7 days after they've stopped the gel. So I'm really not worried that it's not going to come back to normal. It's just a question of, understanding the true bell-shaped curve, as you said. This is designed to be reversible, and I think it will be. And we know that from all the uses of testosterone prior to the study, that once you do stop, things do bounce back to normal, assuming they were normal to begin with.
Okay, thank you. Thank you.
Thank you, Kristen. Thank you very much. Beth, I have a question. So is this study compensating the participants, seeing that it's almost 2 years long? So
yeah, yes. Yeah, so we do compensate the couples for their time and effort associated with the study. They are paid per visit. So, one thing to know as we were talking about all these different phases, those, except for the 12 months of efficacy, that, sort of 4 months and 6 months, that's going to vary because it's dependent upon sperm count. So, if a man only needs, a month to suppress his sperm count in the beginning, he won't have as many visits. So the amount that each person will be compensated for participation may vary depending on how many visits they actually have.
Okay.
But the amount is meant to be commensurate with the time and energy they put
Oh,
into it. So,
indeed, yeah. So male participants, I think the total, if they complete all of the possible visits for the study, it's about $2,500, and for the women, it's about $900. Thereabouts, $850 maybe.
Dr. Barnhart, one last question before we end today's session. I know you did touch upon this, but can you also talk a little bit more about some of the risks that you see associated with this trial, if there are any?
Yeah, there are. Testosterone replacement two things can happen with testosterone replacement, and we're looking for this very carefully in the study. Remember that progesterone is used to suppress the sperm count, and then we're giving back the testosterone so the man has normal symptoms. Theoretically, if the dose is too high, people can have symptoms of over testosterone, and we want to make sure that isn't the case. High blood pressure, enlargement of the prostate, blood clots, things like that. So we want to make sure that the level isn't too high and there aren't any risks in that aspect. The other side of the coin is we could be giving them too little, and they could be having signs of low testosterone, decreased libido, decreased energy, hot flashes, and we want to make sure those aren't the symptoms as well. Honestly, we think we're probably underdosing rather than overdosing, which is why in this study there's what's called a sub-study, that when we check a man's testosterone during the study, if it is too low, or if he is experiencing symptoms of low testosterone, like low energy, we can enroll him to say, well, let's give you a slightly higher dose to see if that alleviates it. So, the study has 2 doses actually of testosterone. We're trying to figure out which is the best one. And again, I think we're, for safety reasons, underdosing rather than overdosing. But if we think we are underdosing and the man is not comfortable with it, or this is affecting his life, then we have a way of increasing the dose to make sure that things get back to normal.
Thank you, Dr. Barnhart. We just heard that expanding, the study is definitely looking at expanding male contraceptive options with safe, effective, and reversible tools, which will make family planning more of a shared responsibility between women and men. On that note, we conclude this discussion today. Thank you, Dr. Barnhart, Beth, Logan, and Kristen. It was great having all of you on Cure Talks at Penn. Thank you.